Our next presentation is regional variation in patient selection practice pattern and outcome based on technique for carotid artery revascularization in the Vascular Quality Initiative. And our presenter is Dr. Hannah Dakor, our RD.
Good afternoon. We thank the Society for the opportunity to present. Okay. These are our disclosures. We have no financial conflicts of interest to disclose. So significant regional variation has been identified following multiple surgical procedures, including carotid revascularization. Many studies have noted that illness burden and diagnostic practices explain only a small degree of this variation, and the majority is attributed to physicians' beliefs about surgical indications, specialty differences, and institutional factors. The aims of the study is to describe contemporary trends in practice patterns for carotid revascularization and to describe variations in patient comorbidities, indications for treatment, intraoperative techniques across different regional groups. We also aim to evaluate perioperative outcomes based on the technique used for carotid revascularization. A retrospective review of the VQI dataset was performed. There were 19 de-identified VQI geographic regions in this study, and the data was distributed into quantiles based on the annual number of procedures performed per region. So our regions were divided into low volume, medium volume, and high volume, with 956, 1,500, and 1,800 cases per year, respectively. We used standard statistical analysis using multivariable logistic regression, and the observations were clustered with respect to centers to reduce the bias from hospital-level factors. So the total cohort included around 130,000 cases, of which 70% were CEA, 13% were transfemoral CAS, and 17% were TCAR. Overall, there was a trend towards increased utilization of TCAR since its introduction in 2016 and up to 2021. This seems to have been mirrored by a decrease in the percentage of CEA cases. On the other hand, transfemoral carotid artery stenting had small significant changes. When analyzing the individual region group, we observed the same trends despite some interregional variation. However, despite these trends, carotid endarterectomy remained the most common procedure for carotid revascularization, followed by TCAR and transfemoral artery stenting. So we're going to start with carotid endarterectomy. As seen in this really crowded table, there were significant differences in patient characteristics among the three study groups, the low, medium, and high volume groups. Significant differences in terms of age, race, ambulatory status, COPD, presence of anatomic high-risk criteria. In terms of procedural variables, high-volume regions had higher use of general anesthesia, protamine use, patching, and EEG monitoring. On the other hand, compared to low-volume regional groups, high-volume regions had less use of routine intraoperative shunting, drain use, stump pressure monitoring, and completion imaging. When studying the in-hospital 30-day and 1-year outcomes of stroke or death, there were no significant differences across the three groups. However, we did notice an increase in length of stay and non-home discharge in high-volume versus low-volume regions. On multivariate analysis, there was no difference in stroke and death outcomes between the three groups. Moving on to transfemoral carotid artery stenting and TCAR. As expected, there were significant differences in patient characteristics across the different regional groups. In terms of transfemoral carotid artery stenting, the significant differences was observed in race, comorbidities, smoking, and presence of anatomic high-risk criteria. Interestingly, we did note a higher utilization of transfemoral carotid artery stenting for asymptomatic patients with less than 80% degree of stenosis, which is usually used as a threshold for intervention in many centers. This was also seen for TCAR, with a higher utilization of TCAR for asymptomatic patients with less than 80 degree stenosis, mainly in low volume regions. Also, TCAR had significant differences in baseline characteristics among patients, demographics, comorbidity, and anatomic risk factors. We looked at the procedural variables with respect to transfemoral carotid artery stenting, and the use of general anesthesia and post-stent ballooning was lower in high versus low volume regions. On the other hand, these regions had a higher use of protamine, completion angiography, and completion angiography, sorry. As for TCAR, the use of general anesthesia, completion angiography, and post-stent ballooning was higher in high regional groups. However, these groups had lower use of protamine and pre-stent ballooning. So there were significant variations in intraoperative variables. Similarly to what we saw in carotid endarterectomy, there were no differences in the outcomes of stroke or death, whether in hospital at 30 days or at 1 year of follow-up between the regional groups. There was still an increase in length of stay and non-home discharge observed. On adjusted analysis, there was also no difference in stroke and death outcomes between the different regional groups studied. Our last aim was to compare the outcomes of the 3 revascularization procedures. And as seen in the figure below, no significant difference in stroke and death was observed between carotid endarterectomy and TCAR across the 3 regional groups. However, transfemoral CAS was associated with higher odds of stroke and death compared to CEA, and TCAR was significantly associated with a decrease in odds of stroke or death compared to transfemoral stenting. These observations were also seen when we analyzed the regions individually, and as we can see in this figure, transfemoral CAS remained to have worse outcomes in terms of stroke or death compared to carotid endarterectomy and to TCAR. The similar findings were mirrored at 1 year. So the limitations of our study, first, it's a retrospective study. And although we used volume, but the intention of study was not to analyze the impact of volume and outcomes. However, it was just a way to describe our regional variation. So regions were designated as low, medium, or high volume to describe the variation in practices. Some regions' low volume may be more a reflection of fewer participating hospitals and not reflect the true volume in that region. Moreover, we did not evaluate potential drivers behind regional variation. In conclusion, carotid endarterectomy remains the most used strategy for carotid revascularization, and despite significant variation in clinical practice, no significant regional variation was observed in the outcomes of carotid revascularization. Transcarotid artery revascularization, or TCAR, and carotid endarterectomy continue to show superior outcomes to transfemoral stenting across all regional groups. So our study identifies some gaps in adherence to societal guidelines, mainly in terms of intraoperative procedural variability that can potentially lead to worse outcomes. It also highlights the need for uniformity in management of patients with carotid artery disease. Thank you.
When you're looking at the transfemoral carotid artery stenting, were you able to look at any anatomy differences or comorbidities that may have changed the outcome in comparison with the other 2 or with TCAR?
Oh yes, our analysis was adjusted in terms of all baseline characteristics between the patients that were available. Sorry, it didn't show, we just added it to the end of the presentation, but yeah, our analysis was adjusted for these factors.
Louis Cabani from Detroit, very nice study. You looked at high volume centers. Were you able to adjust for high volume operators? And then were you able to adjust for the training of the operator, vascular, neuro, or interventional?
So again, we did look at the regional volumes. We did not look at center volumes. We clustered with respect to centers. Our main aim from this study was to describe regional variation of practice patterns, and we did not look as volume as like a predictor of outcomes. Other studies have addressed that, and if I'm not mistaken, a recent study published showed that a high volume, it's the surgeon's volume which kind of impacts outcomes rather than the center or the regional volume. Thank you.
Thank you.
Yeah, thanks.